afternoon. I bring you greetings from our President Joanne Yard, who is not able to be with us in spirit, in flesh, but I know for sure she will be in spirit with us. And so, on behalf of the Barbados Cancer Association, BACA Inc., I extend a warm welcome to each of you joining us for the Dr. Deborah Brathwaite Annual Cancer Symposium. We are honored to collaborate with the Barbados Nurses Association of America and the Caribbean American Medical and Scientific Association, CAMSA Inc., in hosting this important forum. This year's theme, Cancer Advances, Risk Behavior, and Palliative Care, reflects our commitment not only to raising awareness, but also to promote education, prevention, and compassionate care. We are especially privileged to have such a distinguished panel of speakers. Dr. Lisa Barrow-Laing, PhD, Dr. Wayne Greaves, MD, Dr. Sincere McMillan, DNP, and our own Miss Jessica Odle-Baril, JP. We have also our own Dr. O'Neill Paris, MD, MPH, FAAP, for serving as our moderator and guiding today's discussion. Your presence here, whether as a healthcare professional, advocate, survivor, caregiver, or supporter, strengthens the collective fight against cancer. Together, we continue to push forward in research, advocacy, and support for our communities. We thank you on behalf of our BACA executive. We thank you for being with us, and I wish you an engaging, informative, and inspiring symposium. With warmest regards from our executive head by our president, Miss Joanne Yard. Thank you.
And now we invite the invocation by the Reverend Canon Eddie Aline.
Thank you, Dr. O'Neill. Shall we pray? A good and gracious God of all creation, we gather today with hearts full of purpose and hope for the annual Dr. Deborah Brathwaite Cancer Symposium. We give thanks for the life and legacy of Dr. Brathwaite, whose dedication to healing and unwavering spirit of compassion continues to inspire us. We ask for your blessing upon all those who are here, the various members of our panel for this symposium, Dr. Lisa, Dr. Wayne, Dr. Sincere, and our former Consul General at New York, Jessica. We pray at this time as well for all others involved in situations whereby there is this issue concerning cancer awareness, for the scientists, researchers, clinicians, caregivers, and survivors. May your wisdom, good Lord, guide the hands and minds of all who seek new breakthroughs. And may your strength uphold those who face this disease. And may your comfort be a source of peace for families and loved ones. In our work and in our lives, may we be instruments of your grace, bringing light to the darkness of illness and hope to all who need it. Continue, gracious God, to bless this association as well, that continues to provide ready assistance for persons especially suffering from cancer. So bless us all individually and collectively now as we continue to do not our will be done, but your will be done. Amen.
Thank you, Reverend Aline. And now I'll call on the Honorable Lorenzo Herwood, Consul General of Barbados and New York, to address the group. Mr. Herwood.
Thank you. Thank you. Good evening, everyone. A pleasant evening to one and all. Thank you, Mr. Paris. It is a profound honor to bring greetings on behalf of the government of Barbados and the people of Barbados, and to extend my heartfelt thanks to the Barbados Cancer Association for organizing this very vital symposium. Today's gathering centered on cancer, risks, advances, behaviors, and palliative care speaks not only to the challenges we face, but also to the hope and humanity that emerge when science, compassion, and community come together as one. Cancer touches every corner of our society. No family, no community, no country is untouched. In Barbados, as in many other parts of the world, we are witnessing rising cancer rates, particularly among women and men in their most productive years. This reality calls for urgent and coordinated responses, not only from our medical communities, but from our policymakers, from the advocates, diaspora networks, and everyday citizens. The importance of early detection and preventative care cannot be overstated and cannot ever be overly repetitive. So I shall repeat again, the importance of early detection and prevention cannot be overstated and cannot ever be overly repetitive. Public awareness campaigns, better access to screening, and community education are critical steps in reducing risk. At the same time, the rapid pace of scientific advancement in diagnosis, treatment, and technology offers us new tools and real hope for improved outcomes. But we must also never forget those who live with advanced illnesses. And therefore, the role of palliative care is fundamental. It reminds us that healing is not always about curing, but about comfort, about dignity, and the quality of life. As Consul General, I am deeply moved by the work of the Barbados Cancer Association, and I commend their tireless efforts to build bridges between Barbados and the diaspora in addressing these shared challenges. You are clearly making a difference. Let today's discussions be more than academic. Let them inspire action, and let us collectively commit to building stronger support systems, to investing in research, and to ensuring that no one faces this journey alone. Thank you once again for the opportunity to be here, and I wish you a productive, engaging, and impactful symposium. Thank you.
Thank you, Consul General, for that rather encouraging word. That BACA, of course, are in the forefront of trying to advocate for cancer care and prevention and treatment and palliative care. So thank you very much for highlighting those points for us. I now call on Gail Brathwaite, the sister of Dr. Deborah Brathwaite. Gail has been an ardent supporter of this organization for many years now, and we treasure her as one of our supporters. Gail, I'll call on you now to talk about your sister a little bit.
Thank you, Dr. Powers. First, I have to apologize for my voice because I'm recovering from the flu. Protocol has already been established, so I will not get into that. Welcome to the presenters and the participants to the annual Dr. Deborah Brathwaite Symposium. Joining me today is my sister Sandra Agard, who is on Zoom, and my sister Sherelle, who is here with me today. On behalf of the Brathwaite family, I extend a heartfelt gratitude to the Barbados Cancer Association USA, the Barbados Nurses Association of America, and the Caribbean American Medical and Scientific Association for making this symposium possible. Your dedication to continuing Dr. Deborah Brathwaite's memory and her legacy through this annual symposium is both inspiring and deeply appreciated. I know that Deborah's spirit lives on because of the impactful work and the discussion we share at this symposium each year. This is one of Deborah's favorite annual events, and it used to be held, for those of you who've been with us for a long time, at the Kingsbrook Jewish Medical Center. And Debbie did everything possible to make sure everything was perfect before the symposium. To the panel, I want to give a warm welcome and a thank you to the distinguished panel of presenters. We're excited to have each of you here, bringing your expertise, your insights, and cancer-related knowledge to this symposium. As I mentioned to Jessica earlier, Deborah would be elated to know that the Barbados Hospice Initiative is progressing. Last but not least, I want to thank all of the participants for your engagement and invaluable support. Together, we can foster the spirit of collaboration as your support makes a difference. And support can come in several forms. It can be donation, it can be time, it can be money, whatever your preference. But I want to thank you for your support. Thank you, and look forward to a very productive and informative symposium.
Thank you, Gail. Appreciate
You're
that.
welcome.
Let's go now to some of the presentations that are on the table. And the first speaker is Dr. Lisa Barrow-Laing, and she's a product of Hartson College in Barbados, Claflin University. She got a PhD at the University School of Medicine, Indiana, where she majored in, well, where she was a microbiologist and an immunologist. Did a postdoc fellowship at Harvard Medical School, Brigham and Women's Hospital. She is a lead medical scientist at Pfizer, and where she has established quite a reputation for herself in terms of precision in oncology and genomic testing, which are on the forefront of helping us understand how cancer develops and how we can lick it, basically. She's widely published in terms of targeted medicine. She has experience with HPV and HIV/AIDS, and she has been honored several times by Bayer for her excellence. She received the Pinnacle Award at Bayer in 2025 as a top performer, and other awards previously at Bayer as well, Director's Award for Targeted Medicine in 2023. And we can't say enough about her impact on precision oncology and real-world evidence generation. She is a strong patient advocate, and she also is a mentor to women and youth. She is highly regarded, and we're glad she was able to accommodate us. And I'll invite her to talk about recent advances in cancer care. Dr. Barrow-Laing.
Thank you. Thank you so much, Dr. Paris, and good afternoon, everyone. And really appreciate the invitation to talk to you a bit about the recent cancer advances. As Dr. Paris mentioned, I've been working in the field of oncology now for over 20 years, and I am very excited to share some of my learnings with you. So let us get started. First, I do want to also disclaim that this content is for informational purposes only and does not intend to substitute any medical advice, diagnosis, or treatment. And all participants should consult with their healthcare providers with any questions or concerns that you may have regarding any medical conditions. As mentioned also, I do currently work at Bayer, not yet at Pfizer, but definitely in the pharmaceutical industry currently, and for the last 10 years or so in biotech and pharma. But this is also not a commercial presentation, or in-kind support was not provided for this presentation by any of the affiliated organizations that I have been employed for presently or previously. So with that, let's just get started. As you can see, the agenda here really is laid out for you. We're going to go into some statistics around cancer, cancer screening, as well as discussing identification of genetic alterations, drug development, and then if there's time, a Q&A. And hopefully everybody can see my screen. And I asked a question here, what is the best way to destroy cancer cells? Because some of the prior speakers already did mention that, that's what we're really here for, to try to understand how we can potentially get to a point where cancer is not ravaging so many of our communities. And I found over the last 2 decades that it really does come down to early detection and effective treatments. So let's take a look at some of the statistics currently. In the United States, there are about 300,000 or more deaths that will be attributed to breast cancer, and that's the estimate from the American Cancer Society just in 2025, followed by a similar number for prostate cancer, and then lung and bronchus cancers, as well as colorectal cancer. When you look at the estimated cancer death, you do see over 100,000 patients are expected to die, unfortunately, from lung cancer, followed about by 50,000 for colorectal and pancreatic, respectively. So these are pretty large numbers, and cancer is the second leading cause of death in the US and also in the Caribbean. And if we actually take a closer look at the statistics in Barbados, we see similar trends in terms of the incidence, with the top 3 cancers being prostate cancer, colorectal cancer, and breast cancer, impacting 23%, 13%, and another 13% of patients, respectively. So what actually causes cancer? What is known about that? Well, previously, there were, a lot of research and studies reporting that there are several different risk factors to consider. Some of these are genetic risk factors. Others are exposure to certain chemicals or compounds, including alcohol and smoking. And then diet has become another very important risk factor, and excess body weight as well, actually being associated with over 13 different types of cancer. Also, environmental changes and also UV exposure can cause some types of cancer. But in the terms of what is evolving now, there's a lot of interest in understanding why so many young persons are actually developing cancer. So the graph to the right actually shows age 20 to 49, and this is in GI cancers. And you do see that there is a significant increase of cancer in these patients that are, under 50 years old. So whereas previously it was thought that cancer affected mainly persons that were elderly, now we do see that these GI cancers and other cancer types are actually impacting the lives of young adults. And oftentimes they're being diagnosed at a late stage because providers are, not familiar or do not expect to see such young patients with cancer presenting to them. So the antibiotic exposure and as well as the effects on the microbiome are actively being studied to try to understand if there's any correlation between the onset of these cancers in folks that are of young age. So cancer, as mentioned, is still being detected late stage, and not just for young people, but we do find, again, an example from colorectal cancer. You can see here that in terms of distant cancer, cancer that has metastasized, that's 23% of patients having that in this distribution pie chart. And if you take a look to the right, the 5-year relative survival actually shows that if you were diagnosed or being treated with localized cancer before it spread, the 5-year survival is over 90%. And that is in stark contrast to those who are being treated when it has already metastasized, with this 5-year relative survival of just 16.2%. So again, very critical to be receiving treatment in the early stages. So we have established that cancer death is a problem. I think we all knew that before we assembled here. But then, what are the potential solutions? And we've spoken a bit about early detection, but also there's a prevention, and that's associated with some of the risk factors. And having studied cervical cancer for more than 10 years, of course, I do want to mention the HPV vaccine. Currently, there is a 9-valent vaccine that targets certain types of cancer, including cervical, vaginal, vulvar, anal, and also some head and neck cancers. And in the US, the FDA has approved this vaccine for patients that are ages 9 to 45, both male and female. We're now going to actually take a look at some of the screening measures that are being employed. And then later on in the discussion, we will look at some of the treatments. So in terms of cancer screening, what has changed? Just about 4 years ago, there were some updates by the U.S. Preventive Service Task Force and also the U.S. Multi-Society Task Force on Colorectal Cancer that decreased the age of screening from 50 years old to 45 years of age, and that's depicted in this graphic here. There are several different testing options that are available in order to determine if a person may have colorectal cancer, including colonoscopy. But then as well, especially here in the US, there's an uptick in the amount of usage of stool-based tests, such as the FIT test, which also can be a good screening element to use. And screening can go on up to ages 76 or 85. And so even if you're in that age bracket, it still makes sense to discuss with your provider potentially if there is any benefit for screening for you as an individual. So in terms of breast cancer screening, there's a pretty good consensus from the various guidelines that screening should be done at around 40 years of age and occur annually for most of the recommendations. However, recently there was also a lot of discussion about women who have dense breast tissue and false negative reports because the 2D or 3D mammograms were not sufficient in terms of detecting any tumors that may have developed. So supplemental screening letters, again here in the US, are being sent to women with dense breasts to improve cancer detection. Additionally, AI technologies are also fast approaching in breast screening and being utilized to enhance these images as well, which allows for more accurate detection. So now I will also discuss prostate cancer. Many persons might be familiar with a PSA test, which is a prostate-specific antigen test. And with this test, if you have a high PSA level, it could be an indicator of prostate cancer. However, it could also be associated with some of the various reasons that are listed below, such as rigorous exercise or UTI, etc. So again, with that increased PSA, it's important to have discussions with your HCP. And also the ages for detection for PSA starts at around 45 for average risk individuals, but persons that are Black or of African American descent, they are actually asked to start screening at age 40 years old. At the American Society of Clinical Oncology Conference, which I attended earlier this year, there was actually a test that was featured that is called the PROS test. And this test is actually a 27 gene whole blood signature for prostate cancer, and it is in concordance with tissue mRNA levels. So it measures the blood expression and provides a minimally invasive genomic tool that may also aid in being able to facilitate prostate cancer management. So again, I'm focusing more on prostate cancer, colorectal cancer, and breast cancer for this discussion based on those being the three most common types of cancer reported in Barbados and also in other countries in the Caribbean. And now I do want to get into some of the gene alteration detection. I know many persons may know that there are two genes, BRCA1 and BRCA2, for instance, that play a role in breast cancer. But I do want to distinguish that typically when we talk about these genes, we're actually talking about alterations in the genes because even healthy people have those genes. So there's a lot of push to be able to look more closely at genes and determine if they're altered, if, for instance, there are mutations that exist or amplification or overexpression, which means that you then have a higher number of the protein molecules produced by that gene. Comprehensive testing includes molecular next generation sequencing. And here in the community and academic settings, this is a tool that is being utilized more frequently in order to determine if there are genetic alterations, whether hereditary, meaning they're inherited from patient's parents, or somatic, meaning that they occur spontaneously. And why is it important to be able to detect these alterations? Well, actually, it can inform clinical actionability. So, for instance, some of the somatic mutations may be able to provide a provider information around whether it would be, conferring resistance or sensitivity to a particular drug. And that is considered then as a predictive biomarker. So with the genetic changes that do occur, there is the NGS sequencing really allows for providers to be able to look at many genes. There are some panels that look at genes over 400 genes or more, and in some cases the whole genome can be sequenced. But typically for cancer, there is a panel of somewhere between 10 to 400 genes that are being sequenced. The DNA is fragmented. It is then processed through the sequencing machine that's depicted here. And then you're able to see a read of the nucleotides and determine if that is a normal sequence as compared to a healthy individual, or if there is a change in the DNA sequence, which may then cause for there to be this mutation that is associated with the disease. So this figure just goes over the different types of material that you can use for NGS sequencing. It can be formalin fixed paraffin embedded, such as from a tissue, or it could be from the blood. And with that, you can do, again, sequencing using panels to look at hundreds of genes. And be able to identify somatic mutations, and also whether or not the patient has what is considered a high tumor mutational burden, which typically is seen when there are cells that have a lot of mutations detected, or microsatellite instability high. And those two, somatic mutations in TMB and MSI, do then predict sensitivity to targeted therapies or immunotherapies, respectively. There's also recently a lot more research being done on ctDNA, which is circulating tumor DNA from the blood, which can also give you a result of positive or negative and help with monitoring residual disease. And additionally, this, such as plasma, can help, and also tumor normal subtraction can help to determine what are the germline mutations. So here I'm just highlighting 50 of the top cancers genes associated with cancer, and also noting that many studies have shown about 40% of cancer patients do have at least one targetable alteration. I've already previously mentioned that BRCA1 and BRCA2 are high penetrant genes, or genes that essentially predict the development of breast cancer. And low penetrance genes are genes where you might have a mutation in this gene and it has a lower association with the development of breast cancer. But there are many other genes there, as you can see, that play a role as well. So if you take a look at colorectal cancer, you do see that there's a very high number of mutations that occur in the BRAF gene. And so BRAF V600E is one of the most well-studied mutations in colorectal cancer. And there are several others that are clinically actionable, meaning that they're druggable, that are listed above as well, including RET fusions and NTRK and ERBB2 amplification, etc., which is HER2 amplification. Now, if you take a look at the prostate cancer, and this data is from the American Association for Cancer Research, Project Genie, you also do see that the one that is at the top, the highest incidence of alteration, is ATM, which is about, I think, 7% or so in prostate cancer. But there are several other genes that are implicated as well that often do play a role in the DNA damage response. So also at ASCO this year, which is one of the largest international cancer conferences held annually, I was very impressed to see data that was presented by Dr. Joanne Nichols and her team, which also includes Corey Nichols, Mr. Corey Nichols, and Dr. Paul Rouse. And this NGS testing did show a high prevalence of ATM variants or mutations. And of course, more research is needed to be able to determine if these particular alterations that were detected are suitable for treatment with PARP inhibitors, for instance, or in combination with other drugs. But there is, of course, a great need for there to be this type of research being done in Barbados so that we can better understand what the genetic landscape is and then be able to assign appropriate treatments, of course, with patients speaking to their providers. And in chatting with Dr. Nichols, she did share that there are plans of opening a sequencing lab in Barbados later this year, which would be tremendously beneficial to the community. So now I'd like to switch over to the drug development, and there are many changes that are occurring. Here, this is actually taken from lung cancer research, but is recapitulated across various types of cancer, whereby decades ago, really the option was chemotherapy. And there's still a place for chemotherapy right now. But as you can see in the 2010s, 2020s, as depicted by the pill form and the DNA shaped, there are now development of more targeted and immunotherapies, which oftentimes are associated with higher response rates than chemotherapy, and also in some instances, a better safety profile as well. So I did want to just step back a bit to frame the drug development process, because the current drug approval pipeline can take approximately 15 years or even more to allow for one drug to be approved out of a candidate of 5,000 to 10,000 compounds. So it is a very extenuating process, actually. Clinical trials typically do occur as part of the drug development process, phase 1, 2, and 3, to be able to determine the appropriate dose and safety as well. And patient participation is a critical part of this process. Of course, many of us are looking at the news and there seems to be so many divisions, but this data here to the right actually shows that 2/3 of Americans see clinical trials as being very important in the development of treatment. And that is across gender, ethnicity, age, education level, as well as political leaning. So certainly a large majority of people do see the importance of clinical trial participation. And it's only because of patients participating in clinical trials that any of these therapies have been able to be brought to market and available then for broader use. So we're going to talk now about targeted therapy. So what is that? At the very introduction, you saw the bull's eye, right? So we are then trying to figure out what is the best treatment for the patient, which is really considered precision medicine. And targeted therapy is a drug treatment that targets specific features of cancer cells to stop the cancer from growing and spreading, typically by blocking the activation site of certain proteins. And targeted therapies, as mentioned, may have less side effects than chemotherapy in some people, but they do not work across all cancer types or for all people. And some of them still do have adverse events. So this schematic just shows you a pathway, and to the left, you do see without any therapy. And what is happening here, this or the PI3 kinase pathway or the RAF-MET pathway, you do see this type of activation that does occur. And when there is a mutation, for instance, it can cause this pathway to be constitutively active. And that actually drives proliferation, growth, survival, metastasis, allowing for the cancer to just continue to grow and grow. So it's almost like if you're thinking about a traffic system only having the green light on, right? And there's nothing really to stop the cancer from growing. So targeted therapies, that is that red light. It actually will block that activation site. And that blocking can occur by the use of development of these small molecule targeted therapies or kinase inhibitors, or also therapeutic monoclonal antibodies that will actually block this downstream signaling. So another very important development, as I showed, even for lung cancer, but across all different types of cancer now, is immunotherapies. And there are several different types of immunotherapy, but based on the limitations we have of time, I just wanted to focus on PD-L1 or PD-1 inhibitors, which actually stimulate the immune cells to fight cancer cells. And these cancer cells often do have multiple genetic alterations, again, being referred to as MSI high or having a high TMB. So now let's look at some of the clinical trials. The clinical trials I'm sharing, some of the data was from ASCO, some was presented earlier on. But I did say that BRAF V600E was a key mutation in colon cancer. And this pathway is showed to the right. So actually earlier this year, there was a study that was able to establish that encorafenib, which is an inhibitor of BRAF, and that's a small molecule inhibitor, And in combination with cetuximab, which is an anti-EGFR antibody, along with modified FOLFOX, which is a standard chemotherapy, was actually very active and effective at treating patients with BRAF mutated colorectal cancer. And I'm just going over this data quite quickly, but to the left is a Kaplan-Meier curve. And really, this is looking at progression-free survival. So when a patient that harbors that BRAF V600E mutation is treated with that triplet combination I mentioned, as compared to standard chemotherapy or even a doublet therapy of encorafenib and cetuximab, who fares better? Who has a better progression-free survival? And the answer here was with the triplet, actually, the encorafenib, cetuximab, as well as mFOLFOX6. To the right, I do highlight some of the differences that are seen in terms of the adverse events. There was some increase in neutropenia rates, for instance, and other AEs that were mentioned, and those that were above grade 10, grade 3 AEs above 10%, forgive me, that is what was highlighted here with the red bars. But overall, the treatment was found to be very safe. And this Brathwaite therapy did actually result in there being an update in the clinical guidelines to indicate that it is the new standard of care for patients with BRAF V600 mCRC. So another study of interest is the Nivo plus Ipi, and this is essentially two different immunotherapies that work to restore the function of T cells. And in this particular study, just skip over the schematic here. Similarly, you did see that this doublet therapy was better than just looking at the Nivo monotherapy. And so with that, and again, very safe with the doublet. And so that is going to bring me to the point of just mentioning that there's a really recent advance as well, is the use of more combination therapies to overcome resistance that often is an issue in terms of cancer treatment. And there are several other advances here in colon cancer that I won't go through, but I did want to at least point out that, for instance, the challenge trial was a trial that showed that exercise program for patients that did this program over 3 years, that it actually had a lower risk of recurrence. And it really was just walking for 45 minutes about 4 times per week. And it had a great clinical benefit to patients that were stage 3 colon cancer. So I'm going to go quickly through just a couple other examples, but HER2 breast cancer, for instance, is another very important advance where this gene is expressed on breast cancer cells, or sorry, this protein is expressed on breast cancer cells for HER2, and it is typically overexpressed. And so researchers have developed an antibody drug conjugate, which is an antibody that binds to HER2, but also has a cytotoxic payload that is connected by a linker. And this Destiny Breast 09 trial actually was able to show that with this particular combination, or TDXD rather, combination of the HER2 antibody and the payload that is cytotoxic, that was actually better than the standard of care that was being used at that time. And this new therapy does have even approval for patients that are HER2 ultra low, meaning that less than 10% of the cells actually express the HER2 protein. And finally, for prostate cancer, there is also now a greater adoption of the prostate-specific membrane antigen, PET-CT, which is a scan that really allows for cancer cells, prostate cancer cells that are expressing this membrane antigen to be detected. And it is really allowing there to be greater sensitivity in being able to determine the metastasis, as well as then being able to develop treatments to target PSMA expressing prostate cancer cells. And all of these prostate cancer cells typically do express PSMA. And this test is available currently in Trinidad and Jamaica. I'm not certain that it is available as yet in Barbados. But again, with all of these advances, you can see, for instance, these clinical guidelines showing many different types of treatments available at various stages of prostate cancer, for example. And this particular therapy, which is another novel therapy, radioligand targeted therapy, actually uses that PSMA targeting to be able to bring this radioligand in communication with the prostate cancer cell. And then it releases a radioactive payload that then delivers radiation directly to the prostate cancer cells only that are overexpressing the PSMA molecules. So that does allow then for there to be greater selectivity in how these cells are targeted and also less side effects. So in Barbados, I hope, in years to come, we'll see a lot more clinical trials. I did a quick search in the National Clinical Registry and did find that there was one study to better understand the treatment and care of advanced prostate cancer patients in academic and community-based settings. But certainly, whenever possible, there's a potential to discuss with your treating physicians about the ability to be on any of those clinical trials. And with that, I will really wrap up here just to let you know that there are a lot of studies advancing across different types of cancer. One of the most interesting ones I've seen recently is still immunotherapy. It's a nanobody that can actually bind multiple 3 or more different molecules on cells at one time. So a lot of really tremendous work that is being done. And of course, it would be remiss to not mention AI. The AI is being used not just to help with imaging, but also to predict treatment responses and even to help people who do not have access to NGS sequencing to be able to detect any biomarkers of interest. So many more developments that can be covered here, but certainly I do hope that that quick review is beneficial to you all. And I would like to thank the Barbados Cancer Association USA, the Nurses Association of America, and the Caribbean American Medical and Scientific Association for the invitation. My husband, Dr. Brian Lang, for review, as well as my mentor, Dr. Cynthia Quince, and then family members who have been tremendously supportive throughout my general journey. So with that, I'll stop there, and thanks again for your attention today.
Thank you very much, Dr. Barrow-Laing, for that extensive survey of what's new in cancer research and development. And obviously, a lot of these discoveries pertain to people in developed countries and not yet mainstream or not yet in the general population worldwide. So we're looking forward to some of these things being implemented in other countries, and glad that Barbados is actually in the forefront of some of these experiments with precision oncology and genomic testing. Thank you very much indeed.
Thank
Much
you.
appreciated. Move on now to our next speaker, who is Dr. Wayne Greaves. I'm talking about cancer risk factors. Wayne is a Harazonian as well and went on to McGill University for medical school and did pharmacology and his residency there at McGill as well, before going on to Vanderbilt University, where he studied infectious diseases. After that, he had a stint at the CDC and went on to Howard University, where he spent many years as chief of HIV clinic there, and he's contributed greatly to the literature back then in the early days, and was even awarded a presidential medal. Was it a medal? A presidential award for his work in HIV care. Wayne is currently distinguished scientist and executive director at Merck Research Laboratories. He's an avid researcher in terms of viral drug development. Is drug development for viral diseases, and also he's a great teacher, and I think you'll enjoy this presentation today as he talks about risk factors for cancer. He's also avid, like Dr. Barrow-Laing, he's an avid promoter of equity in healthcare, especially cancer care, and he's out there doing his bit for the community in terms of education and mentoring. And great photographer, great cyclist. Welcome. The floor is yours.
Okay, thanks, O'Neill, and for the invitation. Before I start, I really must commend Dr. Barrow-Laing You know, if I listened to you much longer, I'd want to switch my specialty and become an oncologist. It was so good. So thank you so much for that.
Thank you.
I'm going to be speaking a little bit more simply. I'm going to be talking about risk factors in general for cancer. And I'll go through pretty quickly a lot of, but some of what I'd say it's been touched on at least, but I'm more taking a broader view so we can see how things go. So the first point I'd make is that, you know, we'd all like to avoid cancer, of course. We like to know what the risk factors are. And we know what the risk factors are for some cancers, but not all cancers. So we'll look at a few of these. Most cancers are caused by a mix of factors, though. And these factors can be divided basically into some that are modifiable, things like lifestyle behaviors or exposure to various toxins, and others are not modifiable. And here we're thinking of things that are more driven by age or by genetics. And I just show here some of the modifiable risk factors are things like diet, physical activity levels, toxic exposures, lifestyle, cigarette smoke and alcohol consumption, immune health, and stress levels. So first I'll talk about tobacco use. And this is common knowledge, but cigarettes, cigars, smoke is tobacco. And the evidence is very, very strong, although the companies for many, many years hid the data, but it's become very, very clear. There's a definite association with tobacco use in many of these cancers that I show here: lung, oral cavity, larynx, esophagus, bladder, pancreas, kidney, cervix, and others. And what we now know is that any level of tobacco use seems to increase the risk, but the intensity is what drives it even more so, as well as the duration. And of course, the way to approach this is don't start, if you do smoke, to quit. Alcohol is another common factor that we encounter. And here again, the evidence is very good, and it shows that there's a dose-dependent relationship to alcohol, to the point where now we're saying that there doesn't seem to be any safe dose of alcohol in terms of its ability to cause cancer. And there was a time when I don't want to say idolize it, but it made it seem as though drinking was not such a bad thing, at least moderate drinking, often portrayed as harmless or even good for your health. But over time, in the last few decades, growing research has linked alcohol use to at least 7 types of cancer, which you can see on the right. And in some cases, even less than 1 drink per day can cause the risk. And here we're looking at oral cavity, the mouth, throat, voice, larynx, esophagus, breast, liver, colon, rectum, and there's even some association to a lesser extent with bladder, but these are the main ones, these 7 types of cancer. So what about weight? Being overweight or obese? There's also evidence for this association with many cancers, not all cancers, but the ones that seem to be most strongly associated are endometrium, breast if you're postmenopausal, colorectal, pancreas, and adenocarcinoma of the esophagus, kidney, and a few others. Risk seems to increase with the higher the BMI and with central adiposity, or the weight around the belly as opposed to other parts of the body. Again, to attempt to deal with this risk factor is to aim for a healthy weight through balanced diet and regular physical activity. I know this is something that we talk about a lot, but of course it's easier to say than to do, but this is the goal. I'm glad that you heard about the importance of exercise. I think people tend to gravitate to thinking more it's what I eat that will cause cancer or what I don't eat. But actually, the stronger evidence that's been emerging is more for exercise as an approach that one can take to minimize or prevent some cancers, or at least mitigate the impact of some cancers. So exercise, in my opinion, based on all the research data, is a much more potent approach to embark upon or take up as opposed to diet. But diet has an important role to play as well, so I don't want to knock it out completely. So physical inactivity is strongly associated with these particular cancers I show here: colorectal, breast, endometrial, and possibly some others. Now, the recommendation is generally in terms of exercise to aim for 150 minutes per week of moderate intensity exercise, or 75 minutes per week of vigorous activity, plus strength training twice weekly. I'd say if you can't do all of this, do something. It's better to do some exercise than nothing at all and not just be a couch potato. And there are many types of diets that are unhealthy. We know that there's an association with high processed foods like red meat and so on, and some benefit from things like low fruits, vegetables, and a plant-based diet, which we probably don't have time to get into, but which is really assuming more and more importance. The evidence here for unhealthy diets is perhaps best for colorectal cancer, where processed meat has been implicated, but possibly for stomach as well and others. So one approach to address this is to work on developing or using or eating a mostly plant-based diet. Don't have to be vegan or vegetarian, but at least move towards being more and more plant-based, because there are many, many benefits to begin by following a plant-based diet. We don't have time to go into details, but just take my word for it. Now, because I'm heavily involved in infectious diseases, this is of particular interest to me. There are a number of infections that are associated with cancer. And here are the ones that I'm focusing on. Human papillomavirus, which has been associated with cervical cancer, but also with anal cancer, particularly homosexual men, oropharyngeal cancer. And then there's hepatitis B and C, which can cause liver cancer. We also know that Helicobacter pylori has been associated with stomach cancer, and Epstein-Barr virus, which is a virus that also causes mononucleosis, but it has been linked to some lymphomas and nasopharyngeal cancers. And then there's human herpes virus type 8, which has been associated with Kaposi sarcoma, which is a rare disease, cancer. We saw it really a lot in gay men early on in the AIDS epidemic and really came to the forefront. And all of that research led to our finding the association between human herpes 8 virus. But it can occur apart from HIV as well. And I didn't mention HIV, but HIV itself, because it's affecting the immune system, has been associated with increased risk of a number of cancers. And this just shows you more graphically the most common infection-related cancers worldwide, showing the stomach, the cervix, the liver, head and neck, anogenital areas. These are the major areas that are affected by cancers caused by infectious agents. Then there's ionizing radiation. We're getting better now at making CT machines that don't really deliver as much radiation or doesn't scatter as much, but excessive CT scans can be an issue. This isn't an issue for most people because you don't have that many scans, but just to be aware of this. Radon exposure in the home, which you probably know about, and then there are other kinds of occupational exposures, which I won't go into right now. The kinds of cancers that emerge after exposure to radiation, high levels, are things like leukemias, thyroid, lung, breast, maybe a few others. But leukemias and thyroid, and then lung, those are the ones that I'd put at the top. So we want to reduce unnecessary medical imaging, particularly CT scans, not MRI scans in this case, but CT-driven scans are the ones that we'd worry about. And you might also pay attention just because even your dentists now, they're using more and more CT scans. So it's not just, medical scanning where you go lie in a tube, but dentists are often using now a lot more CT scans. But as I said, they're now moving towards green scanning, meaning that they're a little bit less toxic in terms of radiation. So that's a good thing. Ultraviolet radiation, the sun, excessive sun exposure is not necessarily a good thing. And it's great for vitamin D, but it can be overdone, particularly when you're exposed to the sun in the middle of the day or from between 10 a.m. and 2 p.m. Very, very intense exposure, particularly if you're in the tropics, Caribbean, for example. This is a big risk. And I always remember the case of Bob Marley with melanoma, melanoma is a very tricky cancer. You can see that the cancers that are associated with UV radiation are basal cell carcinoma, squamous cell carcinoma, and melanoma. Melanoma can be deadly, very difficult to treat, hard to detect sometimes because it can be hidden in places where you don't necessarily see it. And it can be very small when it starts, but it can spread fairly easily, and it's not the easiest cancer to treat. We're, of course, developing newer and better drugs for this, but it's still an issue. So it's important to be aware of this as a potential risk factor from excessive sun exposure, particularly starting at an early age. That seems to be one of the key factors. Then there are occupational carcinogens and air pollution. Occupational carcinogens, years ago, we realized that exposure to asbestos, people ripping up ceilings and places where their insulation, where they're exposed to asbestos, develop specific kinds of lung cancers like mesotheliomas. Then there's benzene exposure being associated with leukemia, and a number of other industrial toxins, including things like diesel exhaust although air pollution, which I won't say much more about. The big one here, I think, that really came to the forefront that made us become very aware of this are things, asbestos was a big one in benzene products. Then there are other exposures even in the workplace, people who work with carcinogenic agents like formaldehyde and many others, they need to be aware that there are risks to being exposed to some of these toxic things, paint strippers, so on the right. So let's now just skip quickly to the non-modifiable risk factors. I talked about age as the single strongest overall risk factor. Most cancers tend to occur in older adults. As we get older, our immune systems aren't as good at detecting foreign antigens and tumors and dealing with them, or NK cells and other important cells in the immune system aren't as effective. It's also important to pay attention to family history and various inherited gene variants. You heard about a number of them. I'll just mention a couple of them quickly here. The big ones, of course, particularly for breast, and also to a lesser extent now, but important, BRCA1 and BRCA2, but BRCA2 has become also very important for men with prostate cancer. It's usually the kind of cancer that doesn't respond as well to things like radiation. Often people are promoting surgery for BRCA2, even though the outcome of treatment of prostate cancer for radiation therapy and surgical therapy today is about the same. They're really, advances in radiology have really been incredible, radiation therapy. But these are things to know about, and it's useful to be able to be tested, and then you can talk to your family members. For example, if a man has BRCA2 gene, it's important that if they have other members of the family, particularly sons, that they be tested earlier and not the routine age like 45 or 50 for prostate cancer, but start to test earlier, even at age 40. So genetic understanding and testing and counseling are important for several kinds of cancers. And at the top of the list will be breast, ovarian, and prostate, in my mind. Colorectal and endometrial are also listed here, but I haven't seen them to be quite as common. Lynch syndrome is a particular rather rare syndrome, but also associated with some of these abnormal gene mutations. And then there are other important risks in terms of reproductive and hormonal factors, things that you can't really do much about. But you had early menarche or late menopause, women who are nulliparous, exposure to combined hormone replacement therapy, although that's getting to better and not as definite a risk factors before. But again, screening can be important for these cancers that put you at risk, these conditions that put you at risk for these cancers. HPV testing for cervical cancer, we talked about mammography and other tests for breast cancer, colorectal, stool-based tests and colonoscopy, and so on, and now low-dose CT for lung cancer, particularly in former heavy smokers or current smokers. So I think this is my last slide. Best ways to reduce cancer risk: stay away from tobacco, secondhand smoke, alcohol. Try to maintain a healthy weight. Stay physically active. Don't be a couch potato. Protect the skin from UV radiation. Avoid things like tanning beds. Get your vaccinations for human papillomavirus, hepatitis B, any infections that might put you at risk, like Helicobacter pylori for gastric cancer. And follow screening recommendations and limit unnecessary radiation exposure. Talk to your physicians and whoever if you really need to have the specific scans or tests that you need. And if you work in the settings where there's environmental exposure, be aware of this and take the necessary precautions. And on that note, I think I will pass you back to the moderators. Thank you.
Excellent. Thanks very much. I think those two excellent presentations complement each other, actually. The preventive aspect and the research aspect that looks at precision oncology and genetics. Our next speaker is Dr. Sincere McMillan. Dr. McMillan got her nursing training initially at Stony Brook here in New York, at Delphi, NYU, and she's been on to get her Doctor of Nursing Practice at Walden University, and she's also a trained geriatric nurse practitioner, and that's what she practices at Memorial Sloan Kettering Cancer Center. She has been very, very active in this field of geriatric oncology. She is has a wealth of research behind her her name and grants as well. And she really comes to bring us to the next level here. We talked about cancer prevention and cancer treatment, and we move now to the point where when everything else fails, what happens to the patient. And she's going to focus specifically, though, on geriatric cancer considerations, not palliative care in its full array, but she's going to be very specific about what she does and give us an understanding of what happens at this level, where the elderly with cancer and with oncologic problems need assistance beyond the medical stuff that we do. She will touch on that as well, of course. But here she is, Dr. Sincere McMillan.
Thank you so much. Thank you so much, everyone. And I really just want to say thank you for the warm invitation and the greetings that have been extended so far. As was stated, my career right now is focused in geriatric oncology. And so this is the care of the older adult with cancer. And I'd like to, in your hearing in the next few minutes, talk about some considerations for this population. So here are some objectives. Essentially, we're going to walk through the relationship between cancer and aging, which has already been outlined very nicely by some of our previous speakers. Some clinical approaches, we'll talk about that for those patients who may be at the end of life. We're also going to be talking about palliative care and how that actually impacts clinical practice. And then finally, again, focusing on the adult with some end-of-life considerations. So this graphic speaks to the fact that as we age, our risk of cancer also increases. It doesn't mean that every older adult gets cancer, but what you'll see is that, especially over time, we're seeing more and more cancer in older adults, and especially amongst what I'll consider the older old, right? So if you break up the population of older adults, if you think about it from 65 onward, we're seeing a lot of cases of cancer. And that makes sense because as our previous speaker stated, as we get older, there are some vital functions of our body that change. And so that can put us at risk of cancer. I'd like to introduce actually a case study because this will kind of frame our talk as we move forward. I'd like you to meet Mrs. C. She's 79. She has a past medical history of many comorbidities, including metastatic colon cancer and COPD, which is a stage 3. And for those who may not be familiar with stages of COPD, it's a pretty significant stage. Stage 4 being kind of like the last stage. But she's been hospitalized 3 times in the last 6 months for COPD exacerbations, with the last hospitalization that she was actually admitted for being particularly difficult due to something called delirium, which is an acute change of a mental status from someone's baseline, usually in the face of something like an infection or multiple hospitalizations. So not only did she develop delirium, but significant functional decline as well. There are no further planned cancer-directed therapies due to her declining status, which is not only from the metastatic colon cancer, but all of the other comorbidities that she actually has. So when we talk about caring for the older adult with cancer, the reason why we kind of focus on this population is because we want to make sure that we're giving the right therapy to the right person. So it's no longer kind of like in vogue to just look at somebody and say, oh, because you're an older adult, you can't get cancer-directed therapy. Or because you are an older adult, we're only going to give you a certain type of therapy. What really is the standard of care now, if you look at ASCO guidelines and NCCN guidelines, is to really target the care, the cancer-directed care, to that particular patient. And the way that we do this in such an individualized way is by using a tool like the comprehensive geriatric assessment, which not only looks at the cancer, but looks at all of the other factors in relation to that older adult. So what environment do they live in? What's their social support like? What function do they have, right? Because you can have an 80-year-old who's skiing, right? And you can have an 80-year-old who's in a wheelchair, right? They're both 80 years old, but their level of fitness is different, which could also translate into their ability to tolerate cancer-directed therapies. We also want to take into consideration other medical comorbidities and cognitive status. So when we look at the comprehensive geriatric assessment in the context of caring for the older adult, we're really trying to risk stratify our patients. Where do they fall on the fitness versus frailty spectrum? So if you think of a part of aging as being a spectrum, where does that person fall? And that will also help us to determine, okay, what is somebody's life expectancy? Even in the face of not having cancer, if we have an 80-year-old, again, who's kind of skiing very functionally fit, does that look different than the 80-year-old who's more on the frail side? And if the answer is yes, and if we think intuitively that is yes, then when we add the cancer to the mix, how does that help us to determine what treatment is right for that particular person, right? Because as our first speaker said, there are cancer therapies that have multiple drug or immunotherapies that are involved, and then there are some that are monotherapy. So we again want to make sure that the right person gets the right treatment and not based on age alone. But in the case of Mrs. C, there's an elephant in the room, right? And I think this is where we as clinicians, we as advocates, we as family members and caregivers really have to take a look at the person as a whole and say, where is this person on this trajectory of fitness versus frailty? And that's where we bring in what's called palliative care. I'm going to talk about hospice in a moment, kind of like as a separate trajectory, but in terms of palliative care, really the goal of palliative care is to affirm life, and it regards dying as a normal part of the process of life, even without cancer, right? We are all on a trajectory where we want to have good quality of life, no matter how long our lives are. So palliative care is not really meant to hasten death, but it's also not meant to postpone death. Really, we want to integrate all of the aspects that make us human into palliative care and build a support network around that patient and their family and caregivers using a team-based approach. So when we look at previous palliative care models, essentially what we used to do was we try to prolong life as long as possible at any extent or cost to the patient or family. And then when we got to a point where we said, okay, there's really nothing more that we can do medically, we would refer somebody to palliative care or maybe hospice. And they would only have a short amount of time in those services or programs before they actually met their demise. And so they really didn't have the benefit of having palliative care involved. Newer models are actually saying, okay, we can focus on life-prolonging care, right? With all of the new interventions and all of the treatments that are coming out, there's no reason why we shouldn't focus on life-prolonging care. However, let's incorporate palliative care earlier in the trajectory so that we are, again, affirming life, managing symptoms, and helping the patients live a better quality of life. And then when we get to the point that we're saying, okay, we've exhausted medical management, or in the case of Mrs. C, with multiple comorbidities and multiple hospitalizations, we're addressing the elephant in the room and saying, yes, we think that this person is or could benefit from end-of-life care. We bring hospice on board. And even after the patient expires, we still provide bereavement services to their caregivers and their loved ones, because we know that it doesn't end when that particular person has breathed their last breath. So going back to what palliative care is, it's active, it's holistic. It really is for all ages, for persons who have serious health-related conditions, and that does include cancer, and especially for those at near the end of life. So you'll see here some of the goals. I won't read through every bullet point, but really improving quality of life, preventing suffering, and treating pain, not just physical, but psychosocial, spiritual, emotional pain as well. So as I mentioned, palliative care, if you think about it as a sphere, hospice is a part of that sphere, but it's not the entire sphere. Sometimes I've come across, even in my own practice, where if I mention palliative care, people think automatically that I'm talking about hospice, and it's not the same. So we'll talk about hospice shortly. There is an urgent need for palliative care, not just in the US, but globally. So the World Health Organization actually estimates that every year, over 56 million people are in need of palliative care, most of whom live in lower and middle income countries. And I think this is a really important point to drive home, that these services should be available to everyone. 90 million Americans are actually living with a serious illness, and this number is actually expected to increase. And almost half of Americans have not had discussions about what they would like the end of their life to look like with anyone, right? And so this really shows that there's a lot of room for us to get better in the palliative care sphere. So again, for sake of time, I won't read through every bullet point, but you may be asking yourself, how do I know when palliative care is right? Or how do I bring up the topic of palliative care if you are a clinician? Well, you can look at a couple of things. You can look at the presence of a chronic illness, some of which are listed here on the slide, including cancer, even without metastases. You can look at the functional loss of a patient. So for example, with our case study with Mrs. C, we noted that after her hospitalization, she had significant functional decline. So if you have somebody who's more dependent on caregivers or hired attendants at home to maintain their inability, to maintain, their ability to kind of function, that can be another reason to kind of use as a gateway into the conversation of palliative care. And anybody who has unmet needs, so not just symptom management needs, but also guidance with healthcare decisions, or somebody who's had frequent hospitalizations, these are also really appropriate time points in which to enter palliative care. How do we practice palliative care? Well, essentially, it is a team-based approach, and we really want to be collaborative when we are talking about palliative care. We want to make sure that the patient stays at the center of the care, that we can help them elicit what their goals are, but that we also bring in, again, all of those human aspects, the spiritual, the emotional, the psychosocial, the medical, to really help maintain dignity of that person and their family. The reason I have a seatbelt here is because, again, I get asked the question, well, will palliative care or the discussion of palliative care erode hope? And it's actually a very good question, but I say this to you in kind of response. When you put a seatbelt on, do you think that, oh, I'm not going to get to my destination safely? 9 times out of 10, that's not even in your head. You're just thinking, I'm doing this to protect myself in the event something happens. And so I think that's the way we should start framing the discussions of palliative care. And it's not saying that something is wrong or something bad is imminent, but what do you want things to look like for you? And I think it's very empowering for the patient, especially if they have the ability to participate in these conversations. So how we start the palliative care conversation can look different. It will depend on the patient. It will depend on their culture and their background. It may depend even on family dynamics. But one tool that I have found very helpful in my practice is the SPIKES tool. And SPIKES is actually an acronym, and it helps us to deliver bad news. And we can actually apply it to the cancer setting. So here's what SPIKES stands for: setting up the interview. So making sure that we are in a place where we have the time as clinicians and caregivers to dedicate to having these conversations with our patients and loved ones. The perception, right? So tell me what you understand about your diagnosis or what you understand about palliative care, because this is the opportunity for us to really kind of identify gaps and to eradicate any misconceptions or perceptions. Invite the client or the patient to share information, right? Before we start to kind of elicit and give all of this kind of like medical things to them that could be overwhelming, really to invite them and say to them, hey, are you ready to have these conversations? Sharing knowledge, and this goes both ways. Responding to emotion, right? If we're going to really be giving somebody information or news that we would consider, I'm going to use this in quotes, bad, then we really have to give them space to process that emotionally even if that means we're sitting in silence with them. And then finally, summarizing the discussion and leaving room for next steps and further conversation. So some strategies to communicate with patients, and I can also say this for loved ones, because this has helped me when I've had goals of care discussions, is to make sure we're speaking the same language. Outside of being able to speak English, right? Which even if English is not somebody's primary language, we can definitely make sure that we have interpreters to make sure that our communication is good. But also making sure that we're looking at nonverbal cues, making sure, and I speak to, as a clinician here, that I'm not running the show, right? That the patient and the family are really, again, at the forefront of the conversation. So using more open-ended questions, seeking clarification and allowing space for the patient and family to do that. And again, using silence where it is appropriate. A key point that I always like to talk with my patients about, irregardless of age, but especially among my older adult population, is appointing a healthcare proxy. I think this is one of the single most important things that we can do as a clinician, because the healthcare proxy, when the time comes, is the voice for the patient. So the patient can appoint somebody who can speak for them in the event that they cannot speak for themselves. It can be a family member, but it doesn't have to be a blood relative, just somebody that that patient trusts and somebody who has the ability to speak on that patient's behalf. There are even some healthcare proxy forms that will allow the patient to write in their wishes so that, God forbid, that healthcare proxy in the middle of everything happening doesn't understand or remember what that person says. It's clearly written down. So now speaking about hospice, which again is that extension of palliative care. In the United States, hospice is actually a covered entity. So for our older adults who have Medicare, for those who have most commercial insurances, it is a covered benefit. Essentially, to enroll in hospice, there needs to be a prognosis of 6 months or less if the disease were to take its natural course as determined by a clinician. The patient must be willing to accept comfort care or palliative care and forego kind of like the regular services that are more treatment based towards a cure. The primary goal is quality of life and symptom control, and hospice can be provided at home or in an inpatient facility if somebody is more acute or the needs are more acute. At the end of life, symptom management and pain control are of paramount importance. We really want to focus on a stepwise pain management approach. And if somebody is on home hospice, this can be done by a caregiver or family member, but they're not doing this alone. This is in the conjunction of hospice-trained clinicians and staff who are there 24 hours. The goals of at end of life are to relieve suffering and address emotional and spiritual distress. I've had many patients who are at the end of life and their family members are asking me about things like feeding them. Is it safe to do so? Should we do so? So I do just want to highlight that there are significant shifts in what our body needs when we transition towards the end of life. And so whereas, you know, food has a very cultural tie to it, there are some patients who continue to eat, but may eat less, and there are some patients who don't eat at all. And that can be challenging to watch, but the patient is not suffering. Their needs have changed, right? And so also another point that I want to bring out is cognitively. Some patients at the end of life can develop cognitive changes, which would include cognitive decline. This can be a normal part of the process. And I always encourage family members to, as much as they are able, to be there, to reminisce with the patient. Even if their eyes are not open, I do believe they can still hear. And so making sure that, you know, if there's anything you want to say, music that you want to be played, prayers that you want to be said, that you do that at that time. And again, once the person has passed away, hospice care doesn't stop. You as the caregiver or a provider, or even as a clinician, right? Because we can become very attached to our patients as well. There are spiritual, physical, emotional needs that extend beyond that person that has passed away. And so hospice really, among one of its vital services, is grief counseling and bereavement support for family members, caregivers, community members, so that they can find meaning and actually be able to move forward through the stages of grief and loss. So in conclusion, I just want to highlight that knowledge and confidence of the concepts of palliative care are vitally important for clinicians, family members, caregivers, and patients. Our goal really is to advocate for the patient, and really, as clinicians, I think one of the best things we can do is to start conversations. They may not end with us, but if we plant the seed, somebody else can water that seed, and hopefully the patient gets what they deserve and what they want at the end of their life. So I thank you so much for your attention, and I know we'll save questions for the Q&A. So I will turn it back over to the moderator. Thank you.
Thank you very much, Dr. McMillan. I think we have come full circle. We talked about research, we talked about prevention, we talked about end of life, and now we move on to more information on a project in Barbados that's dear to my heart and to the next speaker's heart as well. This speaker is, of course, Jessica Odle-Baril. Jessica has a very storied career in many, many different fields on entrepreneurship, diplomacy, government service, etc. And she's larger than life. She's really a great advocate for cancer services. She in fact was the inaugural chairman of the Barbados American Cancer Association, and was instrumental also in developing a sister branch in Barbados called the Barbados Association for Cancer Advocacy. She and others have been advocating for some time now for a palliative care facility in Barbados. There's none, as you know, and she's going to talk about where we are with that project. She is, just to mention some of her accolades, she was the senator in the Barbados Parliament, Consul General of Barbados at New York, assistant to the Prime Minister, and now Director of Protocol for the Prime Minister's Office. And I present to you now a lady who needs no introduction, actually, Jessica Odle-Baril. Jessica.
Thank you so much, O'Neill. I feel honored to be with this very esteemed group of panelists this evening. And I'm speaking from my heart. I have one single slide, which we'll see at the end, because that will tell you and show you where we are. But as O'Neill pointed out, the need for hospice and palliative care in Barbados is grave. At the moment, palliative care is managed by the Barbados Association of Palliative Care, the president of whom is a member of the BACA Barbados, simplified BACA Barbados. This gives tremendous assistance to the very much needed hospital beds at the Queen Elizabeth Hospital, where, Dr. McMillan, a lot of people just send their old people and leave them there because they're not able to, or don't want to, or can't afford to take care of them at home, even though they don't have a life-threatening illness, they're just old. So the Barrow Pact does its bit, but it is really insufficient and it is dreadfully expensive. We all now believe that voluntarism in case of hospice helps to carry some of the costs of the burden. Unlike the US, it is not covered care. So as I listened to your presentation, Dr. McMillan, somebody gonna have to bring up a policy about making this part of the offerings in what is really a free health service in Barbados, because for those who are not aware, health care is pretty much free in Barbados at the public setting. Of course, you pay to go to your doctors and so on. And of course, the challenges with free health care is you have to wait your turn. And sometimes, especially in critical illness like cancer, time is not your friend. And so the hospice initiative really started. O'Neill Paris is a very modest man, but it was his idea. And he brought it to the New York diaspora years ago and encouraged the organizations to start raising money towards a project of a hospice, a freestanding hospice in Barbados, where, of course, palliative care will take place also. So O'Neill, kudos to you, but he has kept us going. It has been difficult, challenging. COVID knocked all of the wind out of our sails. I can't stress enough of that. And really, we started over again as recently as 3 years ago. By starting over, I meant going back to government. And I'm pleased to tell you that the government only 2 months ago finally signed an agreement for the lease of a property at a peppercorn rate for 25 years, renewable. And that rate is $1,200 a month. $1,200 a year, I believe that's the math. So we have Coverley House, which is an old estate property. The challenge is it took so long. When we finally got to the bottom, we discovered it was rotten to the core, so it has to be demolished. And they've agreed to give us a free and clear space to build anew from the ground up. We have town planning approval for the project. The project is identified to be the need was a 14-bed hospice. And since the years have advanced from the Barbados, a report that was done about the needs for hospice care, the feeling is that no more than 18 beds, 14 to 18 beds is what is needed. So we're using a phased approach of construction, and we will have 2 buildings, and the first building has 9 beds. And when we get to the slide, I'll tell you, Janelle, you'll see how that's laid out. It is in a salubrious setting, or it will be when we're done with it, with a windmill which cannot be touched. So you begin to create some, Dr. McMillan, of what you talked about, that atmosphere that's peaceful, a lot of green space on the outside, and a functional internal setting where care of palliation, spiritual enlightening as needed, and so on can occur. The cost of this hospice is projected at 2.5 million Barbados dollars. We still have a long, long way to go in raising the much needed funds, but we have enough to get us to where we are. The architect has already been partially paid. The quantity surveyor is about to be paid. We're building relationships with corporate Barbados for photovoltaic panels on the roof, so we can begin to generate some ongoing revenue. Because to build it is one thing, but we have to maintain it thereafter. And this evening is not the time for all the details, but to give notice to the Barbadian community and others on this call, and to those Barbadians and others who are on this panel. We still need all the help we can get, and we can fine tune that, what it looks like. So 9 beds in the first instance. Our ongoing support includes government subvention, because at the time that they gave us the agreement on the lease, which is actually in draft as we speak, we still have to sign it. Government takes a while, T's to cross, I's to dot, but we're patient. We've been waiting, getting more and more gray and more bald in some instances. But a subvention is also committed as part of the overall package. A subvention will give some cash support. No number was mentioned, but you know that there'll be some financial base coming at you, legislated annually, certainly under this particular government. Governments change, politicians come and go, so we hope that we will be able to be advocates sufficient to continue to implement and to request the demands for a palliative and hospice care facility. The model looks at shared space. In the first bank of rooms, it's 2 rooms, 2 beds per room, and 1 single, which of course would attract a paying customer. The model looks at those who cannot afford to pay. The equivalent of the Social Security in Barbados will help offset. So if a senior citizen goes to a nursing home, there's a program which sees their income, their pensionable income from government going towards offsetting the cost of their accommodations. And that same kind of model is anticipated in terms of them being a hospice facility as opposed to a nursing home. Of course, ongoing fundraising. There are a lot of deep pocket people in Barbados, on island and outside. And there are a lot of people who love Barbados and who understand what it is like, even to pass in a beautiful place like Barbados. And there are life stories where people came to Barbados to pass their last days. This facility is not far from Brathwaite International Airport. There is no sound of planes overhead, but an easy transition. So if you came here by your ambulance, you could be at our Coverley Hospice in 5 minutes and enjoy the salubrious atmosphere. There's also an intention to have a thrift shop on location at Building 2, and some retail space for pharmacy or clinician of some sort or sorts to help generate revenue to help offset the brunt of the working capital for the property. We also have enough space to do farm to table, small, but we believe in Barbados that everybody has to grow something. And so there's enough room for a few beds. So some of that produce will become usable in the hospice, and we will build relationship. We cannot run a hospice farm to garden. So you draw in community to be a part of the workings. This is important because cancer and end of life generally in the Caribbean and specifically in Barbados, nobody wants to talk about it. It's still talked about behind closed hands. And so as soon as our contract or lease is signed, we are going on site with an educational piece because we're nestled, the hospice will be nestled in a community. Some new buildings are going around it, and there's an old Coverley aspect. And we're going to invite the community in because people don't want people to die anywhere near them for some strange reason, even though we die in our own homes. So the education piece, and Madam Sincere, and I love that name, perhaps we can invite you to Barbados to be a part of some sort of training. I don't throw that as a sprat to catch a whale, but the value of the information we've gathered this evening, there's a role for so many and all of us to play as we build out this much needed hospice. Construction is going to be at least 2 years out. It takes that long to finalize the paperwork, break ground and get going. There is quiet conversation about an interim space. An offer has come on the table, a property which they're prepared because the offerer, their own small hospital is now being used. People are paying to have a bed, paying a high price. And they have a facility which they said they could retrofit. In other words, make sure it's easily transferable. And BACA Barbados will then look for the beds to put in there so that we have something to keep us going until the main frame structure and the hospice is constructed. So there's a lot going on. It's a lot of work for very few people. And I see some of the BACA Barbados members are on the screen, the BACA USA members on this program as well. So the cry continues to go on and on and on, and it's not over until it is over. So to sum up, Janelle, if you could share for me the footprint of the floor plan of the hospice. This is listed as Block A. In a hospice setting, what you're seeing at the top of the screen is really some storage because there's a number of things needed and an exit space. Hospice entrance and exit are never the same place. And so in reverse, if you may slide the screen up, the top right corner is the single bed space, of course, en suite. Across from that would be 2 beds en suite with enough space so that a family member may be in a chair, because we value and understand very much the need for the loved one to have somebody close to them. Of course, the rooms, this is a footprint, would be privacy screens, etc. As we continue to go down on the left side, all of the beds, all the rooms are double 2-bedrooms with all the accoutrements. And then you come into the mainstay services of the hospital. I can barely read this thing without my glasses. Areas for staff, which is critical. The nurses would make good note of this. You come in with the medical director, the very secure drug room attached to the medical director's space, and most importantly, next to that, the nurses' station. The nurses' station is at item number 4, as you can see, and ignore the checklist on the right-hand side. Item 4 is the area where you will come into the main space. Missing from this are the balconies that will come off of each room. I was one of those adamant that the bed must be able to be rolled out so that they can see green as needed, and the architect has factored that in and the next incarnation will have that for us. As we continue down, we, of course, the necessary space of a restore night room if a member of staff needs to just catch their breath and so on, and a number of bathrooms, etc., which are understood. Keep going up, Janelle, please. And then into the common spaces. On your right is the main entrance to the hospice with a visitor's reception. And then the main room, it is at the moment set up like a sitting room and a dining space, but it is a multi-purpose space where if a patient is able enough and they wanted to do some drawing, or if there was somebody who wanted to come and talk about whatever, that this is a common space which can be formatted to fit the needs on any given occasion. Across from that, of course, much needed laundry, cleaning, and food. And that is it in a real fast snapshot picture. Janelle, thank you for that. Right. So in summing up, at the moment, palliative care at great cost. And if I may add, and again, sincerely, truth is the education around what palliative care is a big, big work still to be completed. And we will be utilizing, Barbados is small, everybody knows that, but CBC, because people watch TV early in the morning and so on, and find ways to showcase what palliation is. I have somebody say to me when I asked, we had a hospital bed, if they thought that they'd like to have the hospital bed for the comfort of their loved one. We're not ready for that yet. He was dead in 2 weeks. And she wasn't ready to deal with it. Diane Sobers, and I don't know if Diane is on the program, who heads up Barbados Association for Palliative Care, singularly manages, with the help of a team around her and doctors, that palliative care program on the ground in homes in Barbados. It costs a lot to have round-the-clock medical nursing care. And so having palliation in a hospice would significantly reduce the burden on individual families. We can't assume that everybody can afford it. And you can look at people, Barbados is a place where people look at you and think you got X, Y, or Z. Well, put that out the window. And so this facility will offer much needed support in that regard. We have money to raise. We're looking at 2.5 million to build out our first 9 beds. And we are going to continue to build relationships across the island and outside. Barbados is small, and everything we need cannot happen on the 166 square miles. And so we've been blessed to have had donations from across the diaspora, the organizations, particularly based in New York. Canada is on the radar, UK is on the radar, and O'Neill is really an advocate in raising funds those ways. And as we sat on this call, I just had another thought of a fundraiser. I'm not going to share it now, but it will come up because the word genes has been mentioned many times today, and that's going to be playing a role in the next fundraiser event. And so I in this very quick snapshot, tell you that we are on target. Hopefully by 2 years at Coverley House in Barbados, we will have the first freestanding hospice in Barbados. And I'm happy to take questions if there are any that I can answer furthermore. Thank you very much indeed.
Thank you, Jessica. And I must say that I mentioned that they're co-chairs of the initiative, and we work very well together. Jessica is, outspoken, bravado, and contacts have augured well for us in the past, and will continue to do so.
Yes.
Thank you very much indeed for that review. Now I'm going to turn this over to Janice Reed, who is the president of the BNAA, the Barbados Nurses Association of America. Janice.
Thank you, Dr. Paris, and good afternoon, everyone. We just had almost an hour of an excellent presentation from our presenters, and we do have some questions in the chat, and I'll address the first question to Dr. Greaves. Dr. Greaves, this question came from Brian Lang, and the first question is, what is considered excessive CT scans?
In terms of CT scans, in terms of excessive CT scans, let me frame it this way. Normally, in the US at least, exposure to sun and to soil, we are exposed to about 3 units, radiation units, which we call millisieverts, generally speaking, a year. The Arbor CT scan delivers anywhere from 7 to 10 units of radiation. It depends, of course, on the type of CT scan, but a typical chest CT scan or abdominal CT scan delivers about 8 to 10 units of radiation. Now, there are some trauma protocols where there's extensive workup in accidents where it can be 20 or 30. Generally speaking, we say that 10 CT scans, more than 10 CT scans a year is a concern, even fewer if there are more high intensity scans. What we do is that we look at the lifetime accumulation risk of radiation, which is like 100 radiation units is considered to be associated, greater than 100 units associated with the onset of radiation-induced cancers. Most commonly leukemias, particularly if the bone is exposed or in people who've had many chest CTs, for example, breasts, and for people who've had many abdominal CTs, then things like colon, bladder. But in general, a single CT scan is very low in terms of the radiation that you get. It's not usually a worry, but I'd say 10 or so a year is concerning.
Thank you for that, those remarks and for that explanation.
Was there a second part to this question, or no, was that it?
No, that was it. Thank you. Thank you very much. The second question is another question for you, Dr. Greaves, and that question comes from Noah Brathwaite. And this question is, please explain breast cancer as a risk factor for ovarian and colon cancer and any other type of cancer.
Okay, so breast cancer is a risk factor in a sense for ovarian, colon, and other malignancies because of the shared genetic factors or genes. Most notably, they're all connected through their association with mutations in the BRCA1 and BRCA2 genes, which confers a high lifetime risk for breast cancer, ovarian, pancreatic, and prostate cancers, and a moderate risk of increase for colorectal cancer, particularly in younger women. So the association is there, but it's because of the common sharing of abnormal genes, particularly BRCA1 and BRCA2.
Thank you. We have a question for Dr. Laing. And Dr. Laing, this question comes from Dr. Paris. And the question is, with all the research going on, is the thinking that we might find a common final pathway to all cancers?
Thank you for the question. Well, I think there are at least 300 known signaling pathways in humans, and they're very complicated, interconnected, and complex. Oftentimes, when you block a pathway, there tends to be resistance because of activation through a different pathway. So I think that is a very difficult to be able to target holistically. Certainly, I think we would need perhaps to use some algorithms, perhaps through machine learning, to help to be able to determine if that's possible. Currently, it does not seem like that is possible. One of the most complete responses seen is with the reactivation of the immune cells through immunotherapies, and that currently has given the most robust efficacy.
Thank you. There's a question for Jessica. Comes from Durette Edmonds, and she's asking if they're going to be meditation room, prayer spaces, or a chapel on site. Is that going to be built into the hospice that will be erected in Barbados?
Okay, great question. Thank you. Spiritual space, yes. You heard me make reference to a old mill wall. That is a space that I am identifying as the quote unquote chapel, of course, subject to town planning approval, but that is very much a part of, and on the floor plan, we have a space which could be a private space, which in the early incarnation could be used for that private chapel type space. So the answer is yes.
And what other support services will you have? Will you have a social worker on site to support for the family members, maybe a counselor with that? I know you did mention nursing support services, but what other supportive services will you have on site?
All of those, yeah, all of those are part of the anticipated programming. Whether they would be permanent on staff or come in as needed is still to be worked out. That aspect of it is more, I don't want to throw that one to O'Neill, but more program specific. But those are the kinds of things that are standard in terms of hospice and palliative care facilities. We also, if I may add, interestingly enough, and OP may not tell this, we just started a palliative care program, and I hope to join him, because if you're working in something like this, you want to understand the nuts and bolts of it. Not that we may necessarily be hands-on, but there is provision in speaking with Dr. Natalie Greaves, there is provision for training of your volunteer people who want to be a part of, so that by the time the roof is on and the doors are open, we have a cadre of persons who are willing to volunteer their time. And again, you know, they call me a beggar. It's true. You have to ask for what you need. There's only two answers, a yes or a no. And so there are many persons who return to Barbados to live after living abroad and harnessing tremendous energies and services who want to be able to give back. In all of our lives, there comes a stage when you realize you can only spend so much on things, but how about giving a little of yourself? And there are people who want to do that. So provision is going to be made for that level of volunteerism. Worldwide, volunteerism is what helps keep the bills low in a hospice and palliative care setting. And we intend to use that sort of model as well. It doesn't mean we don't intend to pay, because of course, already in the conversation, nurses and so on who have to carry the brunt of the work. I'm advised that you really have a doctor in the house all the time with on adds needs, but you always, always have nurses. If any of you knew Peggy Rickinson, who used to head up the Barbados nurses in Barbados years ago, she and I served in the Senate together. She used to say, doctors are nothing without nurses. Well, go figure.
Direct also to ask a follow-up question, is mental health care, will mental health care be extended to the family members of those patients who will be obviously in the
That
hospice?
would be, mental health care, and I'm not a clinician, mental health care is a very wide statement, but I believe that Sincere made reference to the issue of bereavement, even before the loved one passes and following. So all in all services that make for the loved one who is transitioning to be as supported by the family will be made available.
Thank you, because bereavement will be very important post, so that will be really appreciated. There's a comment here. Let's see here. There's a post here to you, Jessica. So I love your exuberance and passion for this project, and thank you for your work. So
if I may just add to that, I don't think it's a secret now that I am considered a survivor. And when we talked a few minutes ago, I had ovarian cancer diagnosed last year, didn't waste any time, got on it right away, dealt with it. In other words, they recommended chemo, just did it. And there's a lot of life to live. So I had this passion before, but lo and behold, here am I got it. So let me help somebody else get through the journey. So all that I need to do is to get going after the needs for those others. I was privileged to be here to be able to get it, the treatment I needed, but some Barbadians don't have the same quick and easy access. So thank you for the compliment. It's a moving train. O'Neill knows that.
I think with your involvement and having had a cancer journey yourself, whatever you have will be very impactful. I know you were sharing some things that you want to do in terms of, in Barbados some of the persons who are actually undergoing current chemotherapy right now, and your expertise and your compassion, your empathy, I'm sure will be quite valuable to those and impactful for those persons who you encounter. So thank you so much for sharing your journey. I don't see any more questions in the chat. I don't know if anyone has their hands raised to ask any questions.
I think
Janelle, are any hands raised? Because I can't see the whole entire screen.
So a question pop up: when will training for hospice staff start? We still have a window of time. So right now we're very focused on getting the documentation out of government's hands, getting the demolition complete and the building up. The training will take a lot less time than the actual construction. So that's in the going forward.
Okay. Thank you, Dr. Livingston, for posting that question. Any more questions?
Am I hearing a volunteer for training? Am I hearing somebody volunteering a doctor for training?
I'm sure you will get some volunteers. And another question, how will the information be shared? So is the information regarding, I think she said this person, Dorette is actually volunteering. Dorette, are you going to volunteer?
You take her contact information after the fact. Thank you very much.
Okay.
I've written it down.
Now, let me address that also. We do have a website, the Barbados Cancer USA, barbadoscancer.org, actually. That's you can access, and there's a membership form available there, and you can actually join BACA Barbados. So we'll put that in the chat so that people can actually go ahead and look at information. This is an extensive website. We're going to be upgrading it pretty soon, but it has a lot of information that would be very helpful those who are interested in participating and helping us on this journey.
Yes, Deborah is interested, so she will be informed of that information.
Yeah.
And this question from Errol Bolden, besides funding, what is your biggest challenge?
I think the challenge is money. So funding is it. We have
Okay.
broken the back on the governmental. We don't have any change of use issues. Money.
One more question, Dr. Wilkinson.
Good afternoon, everyone. Jessica, I know you said that the hospice is earmarked for 2 years, but my reason why I asked about the training is because in the event that the hospice is done before 2 years, we need to have the staff really trained for palliative care, because as nurses know, it take particular nurses to deal with hospice care and in palliative care. So I do believe that the training should start as
Rather
soon as
than later.
possible.
Thank you for that, Cicely. Thank you very much for that. And that's something that we'll take away from here as part of the programming going forward. I just wanted to shout out to Sandra, who just asked about how donations can be made. One of the things that happens stateside, it doesn't happen in the Caribbean. You can put in your will where you would wish donations to go as well. So aside from the friends donating on the event, let me put it that way, instead of flowers, you do instead of, but things like wills and trusts are things that people of color perhaps need to start thinking about more when they want their resources, large or small, to be targeted a particular way. So that's something else that we will include as part of the thinking about the resource. And it is whether it is $50 or $5 million, it's still very much appreciated.
And Dr. Wilkinson, there's also a pending operations committee that's going to be looking at staffing and training. So that's in the early formative stages.
Thank you.
Okay, I think we've come to the end of our questions, and I'll turn it over back to Dr. Paris for a vote of thanks. Thank you all.
I thanked you, and I said I was going to turn it over to Daniel Rouse, who is the president of the Caribbean American Medical and Scientific Association, to give a proper thanks to our guest speakers and the audience. Daniel.
Good evening, distinguished guests, respected speakers, colleagues, and friends. On behalf of the organizing committee of the Dr. Deborah Brathwaite Annual Cancer Symposium 2025, it is my honor to deliver the vote of thanks. We are deeply grateful to Dr. Miss Linda Watson-Lord for sharing the warm words and welcome from Miss Joanne Yard, the president of BACA, who could not be with us in this virtual space, and the Reverend Canon Eddie Allen for grounding us in the invocation. We also extend heartfelt appreciation to the Honorable Lorenzo Herwood, the Consul General of Barbados, for bringing greetings on this special occasion. A special thank you goes out to Ms. Gail Brathwaite, whose remarks reminded us of the enduring legacy of Dr. Deborah Brathwaite that inspires this symposium. Thank you also to her siblings, Sandra Agard and Cheryl Brathwaite, who joined us today on today's call. We are indebted to our moderator, Dr. O'Neill Paris, for skillfully guiding the program and ensuring the smooth flow of the discussions. Our speakers, they deserve the highest commendation, who highlighted research, prevention, end of life, and the hospice initiative in Barbados. Dr. Lisa Barrow-Laing, for sharing the latest insights into recent advances in cancer care, with specifics on the top 3, prostate, colorectal, and breast. Great news, research is ongoing and advances are being made, including targeted therapies and novel breakthroughs. Thank you. Dr. Wayne Greaves, for his thoughtful presentation on cancer risk factors. He highlighted the importance of doing something, and that a mainly plant diet based and a mainly plant-based diet helps in preventing cancer and diseases. Thank you. Dr. Sincere McMillan, for highlighting critical geriatric oncology considerations. She reminded us that palliative care affirms life and manages symptoms to ensure the best quality of life in hospice care, provides support to family long after their loved ones have departed. Thank you. And Mrs. Jessica Odle-Baril for her inspiring talk on the Barbados Hospice Initiative in Coverley, Barbados, collaborating with the community through farm to table, for example, educating the community and sharing and creating a space where families can be taken care of through palliation and peacefully passing with hospice care. It is not over until it's over. Thank you. We also thank Ms. Janice Reed, the president of bnaa, for leading the question and answer session, which brought clarity and depth to our discussions. A major thank you to the Public Relation and Technology team from BACA and CAMSA for ensuring that we flow, we look, and we sound great in this virtual space here on Zoom today. To the Barbados Cancer Association of America, our partners, the Barbados Nurses Association of America and the Caribbean American Medical and Scientific Association, volunteers, your dedication and support have made this symposium a success. And finally, to our audience, thank you for your presence, your questions, and your commitment to advancing the fight against cancer while ensuring compassionate care for all. Sandra Alling, we are happy you are still here. At this moment, I wanted to invoke a moment of silence for those who have lost their lives to cancer and those who are still in the fight. Thank you. As we close, let us carry forward the knowledge and inspiration gained today with renewed purpose and hope. Have a great rest of your day, everyone. Thank you very much.